Welcome to Code Clips. Today we'll be discussing the 2026 changes, specifically for the lower extremity interventions. The changes we've seen so far from 2025 will have 16 very familiar codes removed, 37220 to 35, and we will have 46 new codes added for 2026. These are structured very similarly in that there's the iliac, femoral, and tibial areas. And then we're also adding the inframalleolar area with 2 separate codes and lithotripsy, 2 separate codes. Same as 2025, there are open and or percutaneous access procedures, but this time they're determined by complexity of lesion pathology. So we have 2 options for this, as you'll note in the code sets. There's a straightforward lesion, which is usually diagnosed as stenosis or 99% occlusion or less. However, the complex lesions will have to indicate 100% occlusion, a TO, or CTO. In our documentation, this will usually be indicated by a 0% flow or absence of flow, and then also collaterals being developed by the extremity. As far as treatment vessels go, the vessel structure is similar. The iliac, femoral popliteal, tibial perineal, and then the new addition of inframalleolar area. These each have specific number of vessels that can be treated for the MUE in the maximum units. So this is a good vessel guide to provide you with that information as a comprehensive indication of what we can bill and perform. So you'll note in the iliac territory, the 37254 through 62 codes, there are 3 vessels in that territory that are considered billable vessels to code from. Common iliac, the internal and external iliac. So we have a maximum of 3 in that area, in that territory, for billing codes. When you look at the codes, you'll see there's you can select 1 primary code and 2 add-on codes. Lithotripsy has also been provided as a new code 37262, and because there are 3 vessels in that territory, you can use it a maximum of 3 times or bill it 3 times. The atherectomy still exists for this territory 0238T, and those can be added to those procedures. The femoral popliteal area has a maximum of 2 codes for that territory because they consider the common femoral and the profunda as one, and then the superficial femoral and popliteal together as one. So any treatments in those 2 areas can be coded as 1 primary and 1 add-on. Lithotripsy has also been added for this zone, or this territory, 37279, and so that's a maximum of 2 units for this territory, one for each of those vessels. The tibial area, there's a 3 max coding limit. We have the anterior, posterior, and perineal, just as we did before. And as before as well, the trunk bundles to the 2 other vessels, the posterior tibial and the perineal. So in this territory, you can have 1 primary code and 2 add-on codes. Lithotripsy this year has not been provided for this area. So for now, it's a suggestion to add 37799 and a possibility of 1 per each vessel with a maximum of 3. The inframalleolar territory has a maximum of 2, and the vessels that they're using for coding are dorsalis pedis and the plantar arteries, which is the medial and or the lateral. Now the pedal arch bundles to one of the above vessels, so if it's treated as a lone artery, then you can code that as your primary code. Lithotripsy, again, has not been provided for this zone, but because there's 2 vessels, we can have a maximum of 2. And there also hasn't been provided any stent or atherectomy codes for this region, which can be billed as unlisted. We may see codes for that in the future. However, in 2025, I haven't really noticed a lot of those procedures being performed in those small vessels. Unlisted codes, just as a note, they should be coded only once for these procedures, and the descriptor should indicate the quantity and the procedures performed, and then you should also provide a comparable RVU CPT code. So this chart is is wonderful for just providing you the maximum units, all that you can consider as far as these new coding scenarios and how many in each territory. Now, the best practice for documentation can be summarized kind of as appropriate for these codes. One thing that I noticed that isn't always there is a diagnostic history. We want this to be brief but concise. It can indicate previous angiographic findings or CTAs. And if none has been performed, then you can simply state that, and any diagnostic angiographies that are done in your office can be billed. You also want to accurately describe each lesion. Name the specific vessel, name where the proximal part of it is and where the distal location of the lesion is, and this can drastically affect coding. You also want to document the report report the percentage of occlusion or stenosis. This is a really good habit just to get in general. Naming that stenosis and its percentage helps us determine the charge for it, the fact that it is billable, and occlusion now in 2026 will have to be documented as total or 100% occlusion. So just for avoiding denials and for best practice, document the percentage of lesion for each lesion that you record. Describe all interventions performed in each lesion accurately, and you can even name the device, that's best practice, and name the vessel it's attached to. Medical necessity needs to be shown for all interventions and angiograms, and these need to provide the decision or the reason for your interventions. One good example of this is IVUS. Sometimes you'll see a physician perform a pull-through, so they'll document that they did IVUS from the aorta all the way to the SFA, and this would not be counted as multiple IVUS. It would be counted as one, especially if there were not findings that were being followed up on and it was just a general pull-through. So we want to provide medical necessity in our documentation for all of these interventions and angiogram. And just a mental note, each document stands alone, so it should not be required for coders or billers to go to different parts of other reports, other interventions that were performed or other diagnostic studies to capture the information that they need for your report. Your report should stand alone with all of its findings, and its previous documentation needs to move forward. So some diagnosis documentation notes. Only 100% occlusion is considered complex, and we're on the right side of the slide. That's for 2026. Total occlusion or CTO would be considered a complex lesion, and document is 100% to avoid denials. When you only document stenosis or just occlusion, that is going to be considered a simple lesion, which is reimbursed less than the complex. Usually key indications in your documentation is that the vessel has created, or the leg has created vessel collaterals, or you're noting a 0% or absence of flow. Those will all support the medical necessity for these complex treatments. So let's discuss some of the fee changes for 2026. This has been provided by Z-Health, and it's just a basis comparison between 25 and 26 RVUs for next year. And this is a lot of information. We could use it to examine specific CPT codes. However, when we look at the whole picture and we compare maybe what a physician has performed last year to this year, if doctors regularly are not documenting that complex procedure, the 100% occlusions, as a base level, these simple procedures corresponding to 2025 codes pay less than they did last year. So the only way that we're going to get an increase in revenue, which is it's incredibly possible and very possible, is to document those percentage of occlusions, make sure each intervention is recorded and documented completely with their findings, and also to be able to capture the add-on codes that we're going to discuss in a minute. Not just the add-on codes for each vessel or each territory, but also the ones we had last year, the 76937 and the sedation and different things that we can add, but we have to have them documented. So let's look at some of those. So as far as bundled codes go, there's no change from 2025. This still includes the access, the catheters, crossing the lesions and any devices you needed for that. Angioplasty, unless that's the only one that's performed, we bill that with the regular codes. Guiding imaging, protection devices, and the closure, including the angiography. So that's no change from last year. We shouldn't be having to worry about those again. Those stay the same. If we get rejected on a catheter code, it's generally because it's being considered part of that intervention. So that will just take a little analyzing on our office part. So these are the potential billables. The only one that's been added is the lithotripsy, which is a huge addition for 2026. We have those 2 codes for the iliac and fempop territories that can be added up to the maximum vessels that are allowed for that territory. And so we want to be sure to capture that per vessel. Again, a 76937 ultrasound and then moderate sedation, if they're documented completely and accurately, those can still be billed. Diagnostic angiographies before the intervention or in a different session can be billed. A note on this is that we are seeing a lot of denials based on not having the RT-LT modifier on 75710. Most payers require that now, so you'll want to be sure to add that to avoid that extra step. And then the other interventions that we see typically with these lower extremities can also be billed. And there's a list of them there. A mental note as far as using the 50 modifier. 50 modifier can only be used on bilateral procedures that would capture the exact code and procedure from the other extremity. So I'm guessing we may not see a lot of the 50 modifiers because usually we only treat one extremity, or we treat different interventions in different vessels on the different legs. So we probably won't see a lot of 50s, but don't worry about that. Once you put your codes in, you should be able to identify where the 50 modifier is needed. And so I've had along here on the bottom, accurate details equal higher reimbursements. And that's our theme for this session, is the more details you give equal higher reimbursement. That doesn't mean don't write a paragraph, don't write a page-long summary of what happened before, or how you felt about the intervention, or extra details that you don't need. That will simply take more time. But 1 or 2 sentences can be very concise and capturing the treatment, the results, what vessels you were in. So just think details, simple details, be concise. Now, principles of these coding selections, I won't go through all these in detail because it's similar to what we've been discussing. However, this is a good cheat sheet to kind of get your mind in the pattern of thinking these steps, and it's per territory. So you want to, number 2 is a really important step. Locate the code that indicates the most comprehensive treatment or treatments performed. So last year, if you scan down to the determine comprehensive level, we have different complexities that we have to consider for these codes. The intervention, last year we were provided with a hierarchy, atherectomy, stent, angioplasty. So we don't have that given to us this year to determine the code values. However, we can still use that idea to sort between and figure out what's the most comprehensive treatment. For example, we place a stent versus another vessel, we do an atherectomy and a stent. Well, obviously the atherectomy and stent is going to be the most comprehensive. So that's the one that we have the most comprehensive treatment for, is the first vessel we code and bill for. And then if there's 2 that are the similar ones, we look at the complexity. Is one straightforward and one complex? Well, the complexity would drive our next code selection. Just a few notes on this on the right. Each territory stands alone. So each time you get to the end of coding a territory, you restart the process on the next one. Apply 1 code for each vessel. Multiple lesions in one vessel are considered a single treatment. A bridging lesion is treated as one treatment, and you'll want to code to the distal vessel territory. So say, for example, you have a bridging lesions from the iliac to the femoral territory. Well, that's only considered one treatment. However, to capture the higher payment, it would be coded to the femoral area. That one shows the complexity of the actual treatment. Complex and straightforward primary and add-on codes can be used together. So don't worry about having to mix those together to match the vessels that you treated to capture the value for each of them. Now, new to 2026 is that unsuccessful procedures, specifically if a physician's unable to cross the lesion, should no longer be coded as the procedure code with a reduction modifier. Now they should be treated and coded first for the catheter placement and then diagnostic angiography. IVR has several relevant changes to the industry. I've listed them here for you. A few notable ones are that 75705, which is the spinal angiography. It has an MUE instead of 5, it is now 20. So if you're doing genuine spinal angiographies, those contrast study for that purpose, then you now have a possible billing amount of an MUE of 20. TVAR has some revisions. There's 2 add-on codes that have been added to coronary artery interventions. And so just review those maybe before you run through the steps of your usual procedures. Map those codes. Make sure that there's not anything you're missing with those 2 add-on codes. And also check mentally the revisions and any deleted. So have someone in your office or someone that's responsible for that to be able to modify your super bills and make sure that those are mentally taken into account as you code. The neurointerventional procedures now bundle S&I and follow-up. And then also there's been a lot of the GAE procedures to come through, and it's notable that the Embosine microspheres are now approved for osteoarthritis of the knee joint. And it looks like that it will also transfer to other joints and other areas, but we're just waiting on those changes. And another note on that, I've seen a lot of denials because the catheter codes have been denied along with that. This is treated as a known condition. So just like the fibrosis, uterine fibrosis or BPH treatments, you're going to capture the catheterization. Diagnostic angiograms are not usually paid because it's a known issue. And then you'll want to be careful of your catheterizations. Usually 36247 is not billed with that because you're usually accessing in the knee area, in the femoral area. And so you'll want to remap those catheters to count how many branches you cross, and then that would give you your catheterization codes between 36245, 6, and 7. And then usually you'll see some 8s for the additional because there's usually several vessels that are accessed for that embolization. IVL has new add-on codes that we've discussed already. And a mental note here with hospitals, the C codes that were in existence for lithotripsy last year will continue to be used this year. We haven't been provided with any changes on that. Here's just a brief list of other 2026 changes that could impact your practice. So what are the key takeaways for today? It's our theme, detailed reports equal higher reimbursement. And how do you accomplish this? Record the amount of disease in percentage of all findings, IVUS, and angiogram. Remember that the territories stand alone, so restart your coding in each territory. Also, lithotripsy is now payable per vessel. Record your interventions correctly and capture all of those codes. Thank you for joining us today with Code Clips. My name is Amber. Please visit us again.